Alrighty, so hey guys, as you guys know, my name's Nick. I'm a 3B student. Essentially, we've got a bit of a lovely chat about cardio today. What I really wanted to get across was some of the key principles and things for you guys to go back over if they're not familiar at all, and mix in a couple of questions of stuff that's really, I guess, high yield to know for the exam. Throughout this, for those that are actually here today, feel free to send any questions in the public chat so everyone else can see what you're asking. I have a couple of interactive things as time goes on. When that does come up, message me privately so other people have a chance to answer and, we're not jumping the gun and things like that. So that's pretty much it. If you've got any questions, either for those watching at home or watching live, feel free to message me on Facebook. And yeah, let's go. So it's just an overview of what we'll go over today. We'll start off with talking about the cardiac chambers and circulation. And so heart failure is quite associated with that. We will touch on some of the nasty formulas that are associated with that. Then we'll go through a little bit of the valve disease of the heart as well, a bit about the blood supply of the heart with coronary artery disease there. We'll go through the arrhythmias and things like that. Then some other random monash things that I remember coming up a bit in year two, and they're just sort of handy to know. A really good way to think about it is as if your heart is a house. Now, I think you guys have already had a talk from Dr. Kunar this year about this sort of, I guess, idea that, your heart is a house. And so, the rooms are the cardiac chambers. The valves are like doors of a house. The blood supply is like the taps. And then your electricity of the heart is like your electricity of a house. Nice and easy. So we'll start off with nice and basic stuff. Get ready in the chat, guys. How does blood enter the heart? Just send it to me in chat. Nice and easy. Back to basics. Yeah, beautiful, beautiful. Yep, so from the vena cava is correct, lovely. So we'll click that through. There we go. And then what is the first chamber that it enters? Beautiful, yep, the right atrium, great. And then what's next? Great, ventricle, and then the pulmonary trunk. And then what do we hit on the other side? How does it get back to the heart? Perfect, the pulmonary veins. Then what's next? Yeah, awesome, left atrium. Yeah, you guys are smashing this. Left atrium, left ventricle, and then we've got the aorta. So look, although this sounds like a really basic concept and you've probably had it drummed into you across your 2 years already, you'll still get questions about it on the exam. So it's important just to know and be confident in your thing, particularly the distinguishment between your pulmonary trunk and your pulmonary veins. Okie dokie. All right, next up, we have got another little click through. This time, guys, I want you to walk through with me. How would someone present if, say, they had right-sided heart failure? What are some of the symptoms you might see, focusing on the right side? Yep, so we've got peripheral edema, that's good. What else? Raised JVP, excellent, awesome, great sign to elicit. What else? One more sneaky one. Alrighty, so this is what I had. So I had peripheral edema, as you guys said, raised JVP. You can get hepatomegaly as well, and ascites is a complication of that. So too much fluid in that system, and you get ascites, and then hepatomegaly because it's just too much blood in the liver. Let's contrast that now, guys, with the left side heart failure symptoms. What are we looking for in those sorts of presentations? Yep, shortness of breath, the big one. Orthopnea, good, so short of breath lying down, great. And what's the other one that we always ask about? Awesome. So we've got our dyspnea, yep, so short of breath, orthopnea, the P&D as well is always a great one. Sometimes you'll hear the cough is a frothy pink sputum. I've never seen that before, but they often have a cough if they come in with fluid overload. And then on examination, you hear those bibasal crackles because there's fluid on both sides because it's a systemic problem. Okie dokie. In terms of how we describe heart failure, you can describe it as we did before for the right and left or biventricular where there's both sides present. The other way that's more often used is the, I guess, HEF HFrEF and HFpEF, I think is how you say it. Yeah, essentially it's just the idea that you have a reduced ejection fraction and you've got a preserved ejection fraction. So as you can imagine that the reduced ejection fraction is worse, and that's associated with this, they call it systolic. And then you've got your preserved one, which is diastolic as well. Okay, I hate to do this because these maths just exist and it's handy to know, and they do come up in exams, so it's worth knowing just that your cardiac output equals your heart rate times your stroke volume. Your stroke volume is your end diastolic volume minus your end systolic volume. And then just a breakdown of what's there. It's something you just got to almost rote learn, I guess. In terms of when this applies, say in like a third year scenario, not so much, but definitely handy to know for your second year's exams because it's a pretty easy multiple choice to throw out there. Okay, and then next, just some more ones. We've got the mean arterial pressure, and this one does come up as well. So cardiac output equals I should say again, MAP equals your cardiac output times your total peripheral resistance. And what's really important is that you can then translate that equation onto this other one in terms of the systolic blood pressure plus 2 times the diastolic blood pressure divided by 3. So definitely have your head around that. Definitely have your head around that. You know, you can interpose these two equations on top of each other, and that'll put you in good stead. Okay, so the actual ejection fraction that I was alluding to before, it's essentially your stroke volume divided by your end diastolic volume times 100, so it's a percentage. Now, normally it's about 55%, and heart failure with reduced ejection fraction we regard as below 40%. That said, you can have heart failure that's above that threshold, but if as soon as you hit below 40%, you've got heart failure with reduced ejection fraction. Just saying out to you guys if I'm going too fast or too slow. The other big thing that, of course, Monash love to drum home is cardiac output equals venous return. So if in doubt, that is always the option. Okay, in terms of the causes of heart failure, this is not an exhaustive list. There's plenty more than this, but some of the common ones are ischemic heart disease, so they've had a heart attack before, hypertension long-standing, atrial fibrillation, valvular disease, and alcohol as well can be a cause as well. That's how we then diagnose it. You may actually see on an ECG the causing event. So you may see that they have AF or signs of previous ischemia. You might also see that they've got the left ventricular hypertrophy or the right ventricular. Handy to know what they are. I always forget what the exact links are. The other thing you can do is do a BNP on their bloods, and that will be elevated in heart failure. But really the big one you want to drive home is getting them to do an echo. And that will show you, what the pressures are like in the heart, any wall abnormalities, and get a better idea of what the flow is. Okay, in terms of the management, so this is something that always confused me. And the one thing I knew off the top of my head was, you don't give calcium channel blockers to heart failure patients. That's probably the big one that you need to know. That said, there are some caveats to that where you can give calcium channel blockers as long as they are which ones? Which ones do you think you don't give? Which ones are the ones you think you give in heart failure or you could potentially give in heart failure? Yeah, great question. So why can't we use them? So essentially, there's 2 classes of calcium channel blockers, and one of them is particularly bad for the heart. Yeah, great. So someone's already answered. Yep. So the ones that act on the peripheries, we can sometimes give in heart failure because they're not acting on the heart itself. The ones that act on the heart, which are the non-di side things, those ones. Yep. Probably said that terribly. I'm so sorry, guys. They're the ones that we want to be very careful of using in heart failure. Because it will reduce the contractility of the heart. And with a heart that's already trying to work hard and you're going to reduce that contractility of it, it's a recipe for disaster. In contrast to that, though, beta blockers, because they just reduce the rate of the heart, that's safer to use. And you can use cardioprotective beta blockers, ACE inhibitors, and spironolactone. They're the ones that have actually been tested and shown to have mortality benefits in heart failure with reduced ejection fraction. Yes, you can sometimes. Last line, very last line, in terms of whether or not we use the dihydropyridines in heart failure. But very last line, I wouldn't pick it in a multiple choice option. Just explaining as if you looked at a patient's files and you saw they had heart failure and had a calcium channel blocker for some reason, you might figure out why there. But yes, so the big ones to drive home: heart failure, beta blocker, ACE inhibitor, and spironolactone. So that's your big money there. In terms of other ones that sometimes use, you got your loop diuretic, digoxin, which is a dirty drug, so we often avoid it as much as we possibly can. And then you got your SGLT2 inhibitors, which are often used in diabetic treatment, but there's some ongoing studies, and you'll see a lot of this in future years, that they may be slowly introduced more in the heart failure management because they've been shown to have a benefit there. In terms of some of the fluffy stuff that we always love to give our patients, it's the cardiac rehab, education, your daily ways, and then watching their lifestyle, so your usual SNAP-W stuff. In terms of the very bad things, so if someone is really crook and they're not responding to therapy, you got your cardiac resynchronizing therapy, your defib, left ventricular devices, and heart transplant. Don't need to know about them, just know that those are the options. And if someone is going for those sorts of options, their heart failure is pretty bad. Okay, next up, we've got the valves of the heart. So what is the first valve? If we're following the same passage of blood flow as we did before, what's the first valve that we encounter? Awesome, tricuspid valve, perfect. And what's the next one? Yep, awesome, pulmonary valve, perfect. And what's next after that? Mitral, great. And what's next after that? The final one, aortic, awesome. Great job, guys, you guys know this really well. It's funny though, like these are still options for multiple choice questions between which two chambers does this valve exist. Some people always get confused between the tricuspid and the mitral. Just remember that the mitral valve is bicuspid, so it's also known as the bicuspid valve. And there's a little saying that you always try before you buy. Okay, so in terms of actually listening to these valves, can someone tell me how you might listen to, if you wanted to listen to the left side of the heart, how would you get the patient to behave? This is a bit of clinical skills. I know this probably isn't so much a strong point this year for you guys, but how would you get someone to sort of exaggerate their left-sided heart sounds? Awesome. So breathe, exhale, and hold their breath. So on exhale, yep. And what about for the right side of the heart? Awesome. Yep. So that one's inspiration. So inspiration for the right side of the heart, and then expiration for the left side of the heart. What about for the top two valves? So the aortic and the pulmonary. How do you get someone to exacerbate those sounds? Awesome. Lean forward. That's the one. Perfect. And what about the mitral valve? How do we get someone to make that one a little bit louder? Lean to left. Perfect. Awesome. So essentially, these are really important things to consider when you're doing your cardiac examination, because they'll help you distinguish and show the examiner what valves you're listening to and what exercises you need the patient to do. The other one that you can sometimes do is a Valsalva maneuver, but that's not so much for you guys this year. That might be something you see come up in next year, but don't worry about that one for now. But great stuff. Okay, so essentially we'll walk through a bit more about these heart valves. So the AV valves close against high systolic pressure, and they've got the quarter tendonae that anchor the AV valves to the papillary muscles. That's your first heart sound. Then you've got your semilunar valves, which are the non-quarter tendonae, and they're closed in diastole, and that's your second heart sound as well. So just handy to know that, what the difference is between the AV and the semilunar, because that can help you give a better idea. But at the end of the day, they all just prevent backflow. So the heart scary murmurs. I know these terrified me as a second year, 100%. Even they scare me a little bit as a third year, so don't stress, guys. A big thing is just regurgitation's backflow. Stenosis is the turbulence flow. I've got a diagram on the next slide that might help put that point home a little bit more. When they talk about a diastolic murmur, it's here during the atrial pump, and then the systolic is heard when the ventricles pump. So how these are sort of named, like aortic stenosis is referred to as an ejection systolic murmur, because you hear it during systole, and it sounds, it's like a big whoosh kind of thing. That was an awful sound, I'm sorry. And then you got the mitral regurg, which is pansystolic, because it's pretty consistent throughout systole. And then this diagram that I've got here, handy to know in terms of when they all come up, but yes. Okay, this diagram, it took me a while to get my head around it, but it makes a lot of sense. So when something's able to flow normally, you don't hear any noises, and that's why you don't normally hear any murmurs when the heart's pumping. Whereas in stenosis, which is sort of demonstrated by this turbulent flow, you've got that sort of valve that's not opening properly, and so you've got this disturbance of flow, and so you've got all these lovely little circles, which then represent the sound that we would hear in this. And then, of course, we don't need a bit of a further explanation about regurgitation. If you know The Simpsons, you know what's about to come next in that scene. Okay, in terms of the causes, they can be congenital. Often in young kids, you might see a bicuspid aortic valve exist. They can become from an AMI history as well. Rheumatic heart disease, of course, the history of strep throat. They can just happen for old age. That's quite common with aortic stenosis, particularly. Calcification because of lifestyle factors, and they have an older age diagnosis. And then, of course, there's the wonderful infective endocarditis, which we'll touch on a little more later. Okay, now into the blood supply of the heart. So I'm sure this has been round home for you guys, but we'll go over it just briefly. So in terms of the heart's, I guess the coronary arteries that you've got your right coronary artery, you've got your left coronary artery, and that splits into your LAD, so your left anterior descending and your left circumflex. Don't forget too that there's the posterior descending that also exists, and it determines your dominance. For the most part, it's the right. Then you've got your cardiac veins, I guess. A good way to remember which ones are which, they sort of correspond to how important the respective arteries are. So the coronary sinus is where it all pulls at the very end, but the great cardiac vein, which sounds like really important and proper, is to do with your LAD, which is one of the most important. You've got your middle cardiac vein, which is sort of like more chill, and it's to do with your right coronary artery usually. And then you've got your small cardiac vein, which is more like your posterior and so forth. Okie dokie. Next up, we've got a bit of a breakdown of what is acute coronary syndrome, because this confused me, like your differences between your different heart attacks or different types of symptoms that you might get with your chest pain. It always confused me for a bit. So we're going to go through this first of all. So if we're worried, how do I want to phrase this? Yeah. So if we're worried that someone is having a heart attack, we're going to do an ECG, right? And what are we going to be looking for on an ECG in a heart attack? Great, ST elevation, everyone knows that. Awesome. So then that splits our acute coronary syndrome into two things. We've got our ST elevation and our non-ST elevation. So what it's going to be, what's the formal name for our ST elevation acute coronary syndrome? What's the formal name? STEMI, great, awesome. And then in contrast to that, you've got something that's not a STEMI. Great, awesome, good stuff. Then we're going to order a blood test, or we're probably going to do these two things side by side, but we're going to get some results from our blood test, shall we say. What are we going to see on blood test? What's the marker we're looking for? Awesome, troponin, great stuff. So in a not a STEMI, you're either going to have elevated troponin or no elevated troponin. What's going to be not a STEMI and is going to have an elevated troponin? What are we going to see there? No takers, so not a STEMI, and it's going to be elevated troponin. What are we going to see? Alrighty, so then we've got an NSTEMI, which just means no ST elevation, myocardial infarction. So what the really important thing about troponin is that it shows us that there is ischemia, and so in an NSTEMI there is ischemia, whereas in our anginas we actually don't see any elevated troponin, as well as no ECG changes normally. Okay, then with our anginas, we've got two different types of anginas. Can someone list the two there? Great, so stable and unstable, awesome. And what's the big difference between the two apart from the name? What's the big thing we're looking for on history? Awesome, so symptoms at rest, that's our big thing. So if you've got symptoms at rest, it's unstable. And if you've got no symptoms at rest, it's stable. Now, the big thing is that I probably messed up with this diagram is that your stable angina is technically not part of your acute coronary syndromes, whereas the rest are. This whole flow diagram is super helpful to have in your brain when you're doing a history examination and investigations for a suspected acute coronary syndrome, because it helps you stratify where they actually are, what their risk are, and what the appropriate management is from there. Okay, then we get into some yummy ECGs. So of course, the ECG just looks at the electrical activity of the heart, and that ST elevation can give us clues about where the lesion is. The diagram on the right-hand side, I'm sure you guys have seen this heaps before about the different locations. So let's go through a couple of questions to do with it then. To get started, this one, what have we got here? You don't need to give the full breakdown, just the spot diagnosis. Okay, I've got one. Couple, good. Appreciate the honesty there. Awesome. Okay. So for the vast majority, you guys got it right. They've got an anterior or septal STEMI. So that's likely to be caused by our LAD, so our left anterior descending. And you can see that ST elevation, probably fair to say in leads V2, V3, and V4, maybe a little bit in V5 too. So yeah, definitely that anterior perspective. In terms of a bit of a breakdown in terms of which ones are which, so you guys have nailed it with this one. Then your lateral, if you're looking at more of a lateral picture, you expect V5, V6 to be impacted there. Your inferior one is going to be your 2, 3, and AVF. You're likely to see it more so. Okay, what about this one? Yeah, awesome. Everyone's got it. Yep, so an inferior STEMI, nice and easy. What about this one? Yeah, awesome. So a bit of a mix of answers and probably fairly so. This one I've gone for more of a lateral septal. So yeah, anterior, lateral, then sort of a mixed picture going on here. You got your ST elevation in V2, V3, V4, and V5. Excuse me, and V6. So definitely the laterals involved, and definitely a bit of an anterior picture as well. So potentially this is like a LAD and a left circumflex blockage there. So it might be, before that, those sort of split off with the left coronary artery. So this patient would be not in good shape. All right, last one for now. What do you guys think this one is? Okay, no one's quite got it yet. It's a bit of a tricky one. It's more of a, I guess if you can recognize it, you'll know exactly what the condition is. All right, no takers just yet. Here's a clue. It's not an acute coronary syndrome. All right, this one might be a bit mean. That's okay. All right, so this is actually pericarditis, which presents as your global ST elevation. It's a sort of buzzword you associate it with. You can see like there's ST elevation. Probably like it's relatively in most leads. It's not as nice and clean and crisp as some of the other ones have been. But there's definitely a sort of widespread abnormalities. So I can understand a bit of confusion there. But yeah, big one. Pericarditis, global ST elevation, certain multiple choice. You hit it every time. On the note though, someone did answer hyperkalemia, which isn't a bad shout actually. You got to look for your peak T waves, tall tented T waves. So that's a good shout, and that would show impact throughout all cardiac leads. So not a bad consideration there. In terms of your management then, so acutely, you want to give them morphine. You want to give them oxygen. And the big thing is if they require it, like if they're not dropping their sats, like, if they're still hovering like 99% oxygen, they probably don't need oxygen. Keep it on standby, sure, but they probably don't need it just yet. Nitrates for dilation of vessels. Now, you might hear that this isn't great for an inferior STEMI. If you know that, great. If not, don't stress. It's not a big piece of knowledge for you too. You want to give them aspirin pretty stat. I remember a bit of a story here on my first GP placement back in first year. The second patient I saw came in and just had some unstable angina. So my job was to run off and get the aspirin from the medicine cupboard while the ambo came, which was a fun time. Next up, we've got statins as well. So really important to get those in early. Not only do they have a effect by lowering your cholesterol and such, they also have an anti-inflammatory effect. So quite good in the early stages. Then H is heart muscle equals time. So the big thing is you want to get rid of that clot if you can. So, you're going to break the clots to freedom with your thrombolysis therapy. You want to get them to a cath lab pretty quickly so you can get some stents in there and open that out. And you also get some Clexane in there potentially as well to lower their coagulable state. The way to remember this is just Monash, which is nice and easy. Sucks if you're going to Melbourne though. In terms of the chronic management then, so you got your statin, of course, that sticks around. You got your ACE inhibitor to lower their blood pressure. You got your aspirin, so they'll be on it for life pretty much. You got your beta blocker as well. And then the other thing I should note, sorry, I forgot to add here too, is as well as the aspirin, quite often they'll be on dual antiplatelet therapy. So that's when you bring in the other agents that you might have heard of before, like clopidogrel and ticagrelor, I think is the other one too, that you might have heard tossed around before as well. So that's often indicated for at least the first 6 months, particularly if they've had stents put in. To break down the SNAP-W that we alluded to before, that's your smoking, nutrition, alcohol, physical activity, and weight loss. So essentially just think of everything that you want your ideal patients to do. Probably won't, but you want them to do this. The other thing as well, they can always do cardiac rehab, and then you might consider a bypass potentially. Now, in terms of all of these things, in terms of this first step, this acute management, you'll probably implement all of this before you know if they've got an unstable or a STEMI. Like you won't be 100% sure for sure. The only thing that might be different is their cath lab. You might delay them if they're only having an unstable angina episode. But the rest of it is pretty much the same regardless. And the same with the chronic, like it's going to happen for them no matter what they've got. There's some patients are better suited to getting a coronary artery bypass done than others, but I wouldn't stress about knowing which demographic that is. Okay, now onto the fun things, the electrical physiology of the heart. So you guys have probably seen this train diagram before. I love it. I think it's great. I like trains. But essentially the big thing is to know that the SA node drives everything. Then you got AV node hanging about after, and then your Purkinje fibers. And like, if you knock off your SA node, then your AV node is going to take over, and so on and so forth. So I remember there was always those questions about the patient's heart rate is this, what's the working cell and stuff like that. So good thing to know for this. In terms of the detailed electrophysiology, this gave me a massive headache in first year trying to learn this. The big thing is, I guess the takeaway from this is that your cardiac cell and your pacemaker cell are different. Remember, your pacemaker cell doesn't have a resting membrane potential. As you can see, it's always on the move. Whereas your cardiac cell kind of has some chill moments every now and then, yeah. The other big thing to know is which electrolytes are kind of important. So we can see potassium plays a big role, i.e. why people were suggesting hyperkalemia, which is a fair shout. Your calcium as well is a major player. And so you've got to think about that. If there's issues with those two, you're going to consider some cardiac arrhythmias as well. Feel free to learn this diagram. I strongly wouldn't recommend it. Similarly, I wouldn't strongly recommend learning this diagram. So this is just essentially saying which class of drugs is what and what they do. Now, there's a lot of overlap here. As you can see, there's sotalol, which is a beta blocker. That's actually a potassium channel blocker too. So it's a bit confusing. I wouldn't bother learning it. This is the breakdown of what they do. And yeah, it exists. Okay, now we're going to go through our diagnostic criteria for some arrhythmias. Alrighty, so a big way that I like to think about it is, am I too fast or am I too slow? And you're looking at under 60 versus over 100. Pretty much you can guess that on counting your ECG QRS complexes. You'll know pretty quickly if they're too fast or too slow. Next up is if I'm fast, do I have a narrow QRS or a wide QRS? Now this will help us differentiate between our arrhythmias that are occurring from our atria versus our arrhythmias that are occurring from our ventricles. Now, remember, your ventricle contraction is your QRS, essentially. So if your arrhythmia is coming from your ventricles, then you can have a wide QRS complex. Where if it's from the atria, you can have a narrow QRS complex. As I said just there. And then, am I regular or am I irregular as well is the other one. And the easiest way to do that on ECG is to get some paper and mark it out. Yeah. Okay, in terms of your bradyarrhythmias then, so you got your things that go wrong at the SA node. That just could be sinus bradycardia. You might see it in someone who's an absolute athlete. That's probably your most common circumstance there with in a young person. The other things that can go wrong is at your AV node. You can have your different types of blocks, of course, with your first degree, second degree, and third degree. But we're going to go through those a little bit more now. Okay, so I didn't want to hold that slide up for too long, just in case you all memorized it and could do this one really easy. Let's give this one a go here. So what are we looking at here? And I've badly whited out that box. I'm sorry about that. Which one do we think this is? a clue that all somewhat degree heart blocks. Okay, I've got a shout for third degree, not quite. And if you're answering second degree, you got to say which type. Nice. Awesome. You guys did that really well. Second degree Mobitz 2. So this is where we get a consistently long PR and then we drop one. And that drop one isn't always consistent. It's not like you do 3 and then you drop one. It can be random, it can be very spontaneous. And this is actually one of the ones that you get quite worried about if you see them in a patient. Some of the other ones are kind of more chill. This one's a little bit concerning. So great job picking that one up, guys. Next one, what have we got here? Yeah, awesome. You guys are crushing this. Great stuff. Yep, this is just first degree, and it's just a consistently long PR. This isn't one that you always get worried about in patients. You know, you can see it in young people, and it's just exists. Keep an eye on it. Why is the PR long? Great question. Why is the PR long? Essentially, so remember your PR interval is the distance between is the time. So your P is like your atria contracting, and then your QRS is your ventricles contracting, right? So if the time between that's different, or if it's longer, then that shows that through the AV node, which is where you connect between your atria and your ventricles, that's taking longer for them to get through. Yeah. So for whatever reason, whether that's an anatomical abnormality or an electrophysiology abnormality, something's not quite right there. And it's taking a little bit longer to pass through that AV node. Remember, it should take a little bit, like it shouldn't be an instantaneous go straight through there, but it shouldn't be quite that long. I hope that answers your question. Next up, what about this one? Okay, one person's got the right answer. Ooh, tricky. Alrighty, so this one's actually third degree, and it's completely lost. Sorry. And the way to remember this, and the way to spot it, is you just go through with a little piece of paper and you mark out all your P waves. Now, all your P waves will be the same distance apart. Then you go through and you mark out all your QRS complexes, and then you'll see that they're all the same distance apart. And then what you'll realize is that some of your P waves are co-intersecting with your QRS complexes. And so we can see that this is a bit of a mess. You can see that there's a P wave here, that's a long PR. You got a QRS, and you got like another little P wave here. And then you got your T wave from your QRS. Then you've got another P wave, a QRS. Okay, that one looks all right-ish. Oh, but hang on a second, we're going straight from a T wave to another P wave. And you can just see that they're not communicating at all. So that's a complete block between your atria and your ventricles. And this is the one you get the most scared about. Most of the time, these patients will be at like 40 beats per minute. They'll be like pre-syncopal, or they'll just have lost conscious state. It's not a good state to be in. And last but not least, the other second degree one. Yeah, awesome. Good stuff. Yeah, so this is your wanky backy one. And this is the progressively long PR, and then it skips. Now, the good thing about this one, and the way to remember this one, is that because it's got a special name, wanky backy, it's actually chill. So you often see, you do see in young people. I'm pretty sure a couple of my friends actually have this, which is interesting. But yeah, so you get your progressively long PR, and then just drops. And the good thing is that this one consistently drops. It's not just like, it drops when it wants, like this one. This one's pretty regularly dropping, which is weird to say for an arrhythmia. Alrighty. Next up. So we'll go to our left bundle branch blocks and your right bundle branch blocks. To be honest, I had no grasp on these whatsoever as a second year. So if you guys have any grasp on this, great stuff, and you'll be more than right. In terms of your left bundle branch block, a way to remember it is William. So that's a W. You get a W shape in V1 in your QRS, and then, or it could be in V2, and then you get an M shape in your V5 or V6. And so you can see like the W in William, and then there's the L, which is like your left bundle branch block, and then you've got your M, which is like the shape you see in the last one. Then in contrast to that, you've got your right bundle branch block, which is your marrow, and that's an M in V1, and it's right because and then you've got your W don't know why there's a percent there, I apologize, in V5 and V6. So that's a way to remember your right bundle branch block versus your left bundle branch block. The other thing to note is if you see a left bundle branch block in a patient that you've never seen before, you've got to rule out an ischemic event. Got to, always. The other thing that exists is like a sick sinus syndrome, which is a combination of brady and tachy. And it's just weird. Just know it exists. It's a thing. That's all you need to know. Alrighty, next up, I have got a bit of a breakdown of our arrhythmias again. So we already discussed this a little bit, but we'll go through it again. So what are we first looking at with, if we know we've got a tachycardia, what's one of the first things we're going to want to have a look at on our ECG? What's one of the first characteristics we want to pick up on? Speed. So we already know it's a tachy, but I understand because sometimes the exact speed of something can help differentiate it. So not quite speed. Yeah, rhythm. Is it regular or irregular? Perfect. So that's our big thing. Well, actually, no, I messed up. I've put the other thing first. That's all right. I'm going to go for this approach, but you can absolutely start with, is it regular or irregular? That's my bad. So instead, we're going to have a look at our QRS. What did I say about the QRS before? What does a wide QRS depict? Awesome. Wide equals ventricle. Fantastic. So, yep. So wide equals ventricle. And so if we know it's going to be a narrow one, we know it's going to be an SVT. Then, like I said before, like all you guys put in the chat perfectly, we then look at, is it regular or irregular? So can someone name for me a regular SVT? So a regular tachycardia that occurs from the atria. Awesome. So got lots of good shouts there. So yeah, I've got, I guess sinus tachycardia wouldn't necessarily have a narrow QRS complex necessarily. So your big things are your A flutter. If you don't know what AVRT and AVNRT, just know that they're types of SVTs, and that's all you need to know. Wolf Parkinson White is included in there if you guys have heard that before. But great stuff with the A flutter pickup. That's a good one. In contrast, what's our classic SVT irregular? Yeah, great. Awesome. Awesome. You guys nailing this. If there's one ECG you guys should know to look of, it's atrial fibrillation. This is a great one to pull out. It's quite common. You'll see it on the wards and people will go, what's this one? You'll be like, oh yeah, AFib, no worries. Next up, ventricular. What about a ventricular regular rhythm? Awesome, VTAC, great. And what about an irregular one? VFib, perfect. The other one that you guys should never miss a VFib. Your patient, well, they might not have a chance to forgive you, but your fellow doctors never will. Alrighty, let's go through a couple of them. What is this one here? Again, just have to do a spot diagnosis. Don't need the full story. Okay, I've got one call for a fib. Unfortunately, it's not that because I can see some P waves present. That's just a bit of a clue. I agree though, there is a tachycardia for sure. Not quite. Not quite, we're not seeing a flutter. Okie dokie, alrighty. So this one's actually just a sinus tachy, which is kind of fun. The big reasons why, it's regular, it is a tachycardia. The QRS, I can understand why you guys might think it's a little bit narrow, and it's looking a little narrow. Actually, I want to check that point. I'll get back to you guys about whether or not sinus tachy is, or you can rule out sinus tachy because it's extremely narrow, or whether or not, but I will get back to you with that one, guys. The big thing is though that we're not like seeing a sore tooth appearance like a flutter, and it's just kicking along. So if you were doing some physical activity, this is probably what you're going to be having. Next up, apologies for the poor quality of this one, but what are we looking at here? All right, I think one person's got the answer. Awesome, that's a couple. So if you're wondering whether or not it's a node block, just have a look at the pacing of it. And does it look like a tachycardia to you? Because if it does, then it's probably not going to be a node block. Alrighty, so this one's just AF, nice and easy. Big thing is no P waves, so you can immediately call AF there. But in terms of going for our criteria from before, it's a tachycardia. A bit of a clue when you're trying to calculate is a tachycardia or not is you count the number of QRS complexes and you times it by 10, so times it by 6, and that will give you how many, what is their beats per minute. So you count them on the rhythm strip, so 1, 2, 3, 4, 5, so on and so forth, and you times that by 6, and that gives you how fast their heart is. So this one is just AF, no P waves, irregular, atrial tachycardia. Good stuff. Next one. A bit more going on in this. A bit exciting, a bit exuberant. So the big thing is, guys, we're looking at tachycardia. So, I mean, that helps to start with. Got some calls for VFib. Now, what's the big criteria for VFib? Is it irregular or regular? Great. So is this irregular? Yay, we've got one person who's got it. Yeah, nice. So it's V-tachy, guys. And that's just because it is irregular. It looks cooked and 100% get the VF vibe, but it is just VT. I know it looks a bit weird because V3 probably wasn't placed very well, and that's going a bit nuts. So yeah. This one in contrast. What causes VT? Great question. God, we're meant to know this. Essentially, you're going to think of things like if you're having sepsis, if you're having, there's a great mnemonic. What is it? 4 H's and 4 T's, I think, is your go-to. So have a look at that one, and that will give you all your answers for what causes it. All right, for the sake of time, we'll move this one along. This is just sinus normal, nice and chill. I know it's sometimes tough to see some P waves up here, but don't stress, we do see them down here. Just sinus normal. Last but not least, oh no, second last, sorry. This one should be nice and smooth to get. Yep, one person's got it. Yeah, awesome. Great stuff, guys. VF, don't miss this. Don't miss this. It looks so messy. This one is our last one. Oh no, second last. I got too excited, put too many ECGs in this. Yep, awesome. One person's got it. Yep, so this one's just our sinus Brady. Nice and easy, nice and chill. And then this one, I promise, is our last one. Last ECG. Yay, A flutter, great. So yeah, the sawtooth pattern, that's all you got to look for with A flutter. But again, it does meet our criteria before. We've got narrow QRS complexes, it's regular. The big thing is with A flutter, I know you guys were flagging A flutter before when it was sinus tachy. A flutter, you've got multiple atrial contractions before a ventricle happens. So you can see that there's P wave, and it's either 2 to 1 or 3 to 1. That's a big clue. Alrighty, in terms of treatment, there are drugs you can take. You guys don't need to know them at all. Lifestyle always has a role there. You might use catheters for the confirmation of the cause or ablation in like AFib or A-flutter, and otherwise you might use a pacemaker. You guys don't need to know a lot about the management though of arrhythmias, except, well, not just yet. So you got your AV node blockers, that's listed there, your calcium channel blockers there. Then you've got your antiarrhythmics. Now, I know there was that big diagram before that was quite scary. This is a breakdown of what some of them you might use more commonly. And they're probably not they're probably handy to know just in case you hear them about. And then just a note on AFib, because this is the big one that I think you guys get quizzed on the most. So you got to remember that, like, stroke prevention is paramount, and heart prevention is heart failure prevention is key as well. So you want your rate control, you got your rhythm control, you got your stroke prevention, then you got your disease management, so your SNAP-W, of course, as well. So really important, and good to have an idea about, that your rate control is your beta blocker. Is primarily, you can use calcium channel blockers too, but beta blocker is better. You got your rhythm control, and then your warfarin and DOACs. Okay, then we've got some random things now, guys. This is more like, if you know everything up to here, if you feel reasonably confident with everything up to here, you're going to do great. This is just sort of the icing on the cake. So aortic dissection. So the diagram on the right, you guys don't need to know, but it's good to have a bit of an idea about that there are different classifications and different types of aortic dissections depending on where they occur. The big thing is that you get that chest pain that's like that cherrying chest pain that's radiating to the back. Big thing is that they always put in questions is that the pulses are different. So if you've got an aortic dissection that's occurring, say, where's a good point? Somewhere between your left and your right, split off for your two arms, I guess, then you're going to have different radial pulses on either side. And the same if you've got your type B here, you're going to have different femoral pulses to your radial pulses because blood's pulling whereas it should be going to your leg, whereas it's able to go just fine to your radials. The muffins is always your buzzword there. Okay, then we've got a confusing one between the two of them is aortic dissection versus aortic aneurysm. And an aortic aneurysm is just the bulging in the areas of the wall of the aorta. It's your pulsatile abdominal mass. You can have it leak or rupture. So that's where it's also important to, check your pulses. Have met a patient who had this happen. It's like, apparently it's huge. And we saw the CT, it was just massive. Okay, I know the chest x-ray is not great. I apologize. But this is just a sign that you guys might know there's associated with a particular condition. Does anyone know what this one is? No dramas if you don't. Call for cardiomegaly. Look, I agree. The heart does appear large, but it's not quite what we're after. It's not quite a pleural effusion, although I do get your thoughts there because you can't quite see the left costophrenic angle, but I think that's just the poor image quality. I kind of like this one because once you know it, you don't forget it. Hey, we've got one right answer. Awesome. So it is cardiac tamponade. So it's the water balloon sign on chest x-ray. And that commonly occurs when there's trauma, surgery, post an AMI or aortic dissection. It's the Beck's triad. You don't need to know that you don't probably need to know about Beck's triad. Just know that, if you've got a bunch of blood pooling around your heart, you're going to get muffled heart sounds. Because your blood's not able to return to your heart properly, you're going to get a jugular venous distension. So you see the veins in your neck popping out. You're going to have hypertension because you're losing blood around your heart. So a cardiac tamponade, just in case you guys aren't totally aware, it's just blood in the pericardial space. So your heart's not able to contract properly. And so it gets nice and big. So that's what I was saying with the cardiomegaly. You're sort of right, but you're not quite on the money. Then we've got infective endocarditis. So that's just where bacteria adhere to the valves and the vata leaflets. Your thrombi flick off everywhere and cause damage. Your microbes, I remember there being heaps of questions about the microbes. So if you're an IV drug user and you've got infective endocarditis, it's Staph aureus. If you've had recent dental work, it's Strep viridans. If you've just had a colonoscopy, it's Enterococci. And if you've got valve replacement for some reason, coag-negative strep. Is it always blood, or can cardiac tamponade be fluid as well? Look, probably can be fluid. The thing is, though, I guess you can get inflammation of your pericardium, which is your pericarditis. And that's, I guess, similar, but you wouldn't get that massive swelling that we saw before. The only thing would just be what fluid would you get? That'd be the thing. So I'm probably going to say most likely only blood. But good question. Now we're going to get into the more boring stuff. You got your cardioembryology. So it's one of the first structures to develop. I kid you not, this was a question that we had, is when does the heart develop? It's 3 to 8 weeks in. I had to look that up after the exam. Starts in the neck oral region and migrates down. Look, if you decide to not study cardiac embryology, it's probably not going to matter until your PEDS year. But it's probably good to have a little bit of a grasp on. The big point, though, with the whole of the heart is that there's no oxygen in the uterus. So you've got to find some ways around that. Okay, so the big problem is that we don't want much blood in the pulmonary vessels because, you know, your lungs aren't working properly and there's not much, you don't want much blood there at least, just enough to keep the cells alive. You also want to introduce a way for blood into the fetus from the mother. So your solution is shunts and the umbilicus. So one of the first shunts that we talk about is the ductus venosum, I should say, sorry. And that just bypasses the liver with oxygenated blood from the mother. And so eventually will form the ligamentum venosum in the adult. So I'm sure you guys have seen that in your GIT anatomy. Next up is your ductus arteriosus. So this just bypasses the lung from the pulmonary trunk to the aorta. So it will form the ligamentum arteriosum in the adults. So that's pretty important too, because we don't want too much blood going to our lungs. Then we've got the foramen ovale, and it bypasses the entire pulmonary system like a big shortcut. And it connects the right atrium to your left atrium, and eventually will form the fossa ovalis in adults. So in the beginning, you know, you've got your one inferior entry, which is your SVC and IVC combined, and that's actually where your oxygenated blood is coming from your mum. Then you've got your superior exit, which is your pulmonary trunk and aorta, although we want most blood going into the aorta. You've got your sinus venosus, which will later form the atriums, and then your bulbus cordis, which will later form the ventricles. And these rotate in a really strange fashion as well. This diagram looks scary and intimidating. The big point is 4 is what eventually happens. And so you get blood while there is greater pressure in the right atrium than the left atrium, blood will go from the right to the left. And that's what you want. You want that as a fetus. And then you want it to close. You want it to close once you're born and never be used again. If you do have it so it doesn't close properly, you will get a mild shunt. Now you won't find this normally. It doesn't present with symptoms until you have like a DVT and you get a stroke from it, because, you know, following our blood pathway, that really shouldn't happen unless there's a hole somewhere, and that's where the hole is. The other thing, one of the last notes, is just the tetralogy of Fallot. That sometimes comes up as an exam question. It's essentially just 4 things that make you go, this isn't a normal baby, this baby is blue. And it's because there's a ventral septal defect, so a hole between the 2 ventricles. Like, of course, it's going to cause some issues. You've got your pulmonary valve stenosis, you've got biventricular aorta, because that's a horrible idea. And then you've got your right ventricle hypertrophy from trying to work so hard. Just a thing to know, bit of buzzwords. That's pretty much it. And that brings us to the end, guys. That's all. Big thing I want to drive home, though, is that, you know, you guys don't have imposter syndrome this year. You've worked really hard, and I can't imagine learning anatomy outside the lab, and credit to you guys for doing so. I'm sure you'll all smash your exams, and by being here today or watching these back, you guys will absolutely crush it. Can't wait to see you on the awards in a couple of years' time. Send me any questions you got, and thank you so much.
Thanks very much, Nick. That was awesome. And yeah, so Nick's also available for messages and questions and stuff whenever you want. So and a reminder that the next lectures will start at 12:15. So go have a break and something to eat.
Enjoy the coffee.
Take a coffee. Yeah. All right. Thanks very much, Nick.
No worries. Catch you later.